All right, so this is a brief discussion about history and a brief discussion about the physical neurological exam. And this is an interactive kind of discussion. When does the neurological history begin? When does it begin? The point I'm trying to make is that the neurological history begins as soon as you spot the patient in the waiting room. And as you can see, we have a long walking hall. The hallway is long because in neurology, we do a lot of observation. We see the patients. We want to see how they walk. Anyways, the point is the history begins as soon as you put your eye on the patient. You can take history subsequent to the first time. So it's not as if you have to take 100% of the history on the very first visit. Frequently, there are tests that you do when you bring the patient back. Yes. I don't. Oh, yeah. So frequently, you bring the patient back, so you can take more of a history. The things that we ask for, as you can tell, we ask about the age. We ask about the handedness. Why is the handedness important in neurology? Why is the handedness right-handed, left-handed?
Because left-handed and right-handed people have different areas of brain to control different functions.
Yes,
to find
dominance. So we're kind of interested in dominance. Because in neurology, unlike other areas of medicine, certain a part of the brain that is dominant for speech, dominant for certain activities is important to us. And we get a kind of an insight to that. Now, it's not 100%, right? Because most of us are right-handed. Any of you left-handed, by the way? The three of you are not left-handed. But you can have people who are left-handed and still have dominance on the left side. So that's very important because only the genetically left-handed individuals have dominance on the right side. So you have to ask more questions. If you're interested in that, you have to ask about their parents and grandparents, uncles, aunts. And the patients will tell you, oh yeah, everybody in my family is left-handed. So that's genetic left-handedness. The chance of somebody who's left-handed having left brain dominance is still 50%. It's quite high. But it gives you a little bit of an insight. It's a clue. Let's say it gives you a clue. I always ask about the occupation, where they live. Marital status is helpful sometimes. Military, for example, the trauma, military. Family history, medical background, surgical background, hospitalizations. I ask about their children. I ask about the menstrual period, if it's appropriate, workman compensation. Sometimes it's a legal issue. They have lawyers, forensic cases, medications, of course, we ask medications. And then we do the review of systems. I usually look for 25 bullets in the review. This would include diabetes, cardiac, lung disease, hypertension, GI problems, urinary. And one of the concepts that I wanted to share with you is the ticket of admission syndrome. What do you think that is? The ticket of admission syndrome.
When a patient doesn't know exactly what they're here for.
Okay, well, close. Frequently, the patients do know why they're here, but they don't want to share that because they are embarrassed. So thank you very much. They may be embarrassed or psychologically, they can't get themselves to explain it, right? So we get situations where a person comes in and says, I have a headache. And you're sitting there, you're trying to figure out the headache, but it turns out that they're being abused by their husband. Let's say it's a female, they're being abused by the husband. And they can't quite tell you that. So they come in saying, I have a headache, or I can't sleep at night. That's another one. I can't sleep at night, doctor. And you're trying to take a history and examine them and so forth. And you're still not sure why they can't sleep. One of the thoughts you should have is the ticket. That what is this? They have to show you a ticket to come into the neurologist. So they have to say headache. They have to say a sleep disturbance, or they say I have pain in my arm. But the real reason for that may be something else, and it may not be apparent until the second visit or the third visit. Sometimes, because for teaching purposes, we try to find everything on the first visit. But sometimes it takes me 2, 3, 4 visits to figure out why they're really here. So many doctors naively don't realize that patients have agendas. Okay, little children don't have agendas. And that's one of the nice things about doing neurology in children. They don't have an agenda. Very rarely they may have, but ordinarily 98% they don't have an agenda. So that what you see is pure neurology. Adults seem to have an agenda, and it becomes harder for you to find out exactly why they're here. Okay, we see children here, so we always ask the mother or the father about the gestation, the delivery, how is the delivery, medications use, drug use. Then you find out about the children in terms of achievement, interested about weights, heights, milestones in the children. And then we get to the story of present illness. Always remember medications. Medications can cause all kinds of problems, encephalopathy. They can cause sleepiness or lack of sleepiness, tiredness, fatigue, etc. So drugs, disorders of memory, of thinking. One of the most common reasons we see patients are headaches. Always ask about the 4 Ds. What are the 4 Ds in neurology when you see a patient? 4 Ds. 4.
Duration.
The what?
Duration.
Oh, okay, but I'm talking about more in terms of underlying conditions like dementia is 1.
Depression.
Depression is 2. What are the other 2?
Delirium.
Delirium is 3. And the 4th? Drugs, exactly. So the 4 Ds, very easy to remember. Always think in your mind about the 4 Ds. Always ask a couple of questions about it. So we look for, in the headache, we want to know if there's alteration of consciousness, loss of consciousness. If there's a loss of consciousness, is there an aura? Is there something that triggers it? Is there a seizure, of course, in your mind? Syncope. Syncope is a very difficult one because most of the time when somebody has syncope or faint, we don't discover the cause. 50% of the time, we don't know. Visual changes, loss of hearing. Remember that in neurology, the eyes are just an extension of the brain. So we always think of the eyes as just part of the brain, so we want to examine the eyes carefully. Hearing is an extension of the brain as well, so we want to examine the hearing very carefully as well. Many of us in our training, we went through neuro-ophthalmology, for example. I trained at the Mass Eye and Ear in Boston. All of us went through ophthalmology. Shirley Ray was our professor, who was a neuro-ophthalmologist, wonderful. In hearing, we went through with the audiologists. So we studied hearing even as a separately, neurotology. Some neurologists subspecialize, and that's all they do. But I wanted to emphasize swallowing, change in speech, talking, discussion, family members, and then movement disorder. Look for tremor, look for clumsiness, and then neck pain, back pain, pain in the extremities. And then in pain, I think you're pretty good at pain, how to evaluate pain, so I won't spend too much time. I'm always, you notice I always want to bring a spouse in. I always like to bring in a family member, especially when there's a memory problem. Patients with true dementia almost never come in by themselves. They will come in with a family member who has identified some individual problems. So they'll come in with a spouse, I'll be there. Yeah. So they'll come in with a spouse, they'll come in with a child, they'll come in with a grandmother. Usually they don't come by themselves. So when a person comes by themselves and tells me, you know, doc, I'm worried that I'm developing Alzheimer's. Right away, you think to yourself, this may be anxiety or psychiatric, psychological, or other. It's very rare that somebody actually comes in. Usually somebody well-educated, maybe a professor who says, you know, he's saying to himself they can't formulate a talk or a speech as well as they did a year ago or something. Okay, then it's kind of different. But the average person, usually when they're demented or developing dementia, they come in with a spouse, or come in with a relative or a friend or somebody else. In terms of, I'll just head into the examination process. Neurology is kind of a separate field in medicine. It should not be considered as just part of overall medicine. Like dermatology is kind of the study of the skin, or cardiology, study of the heart, or gastroenterology, study of the GI system. Neurology is a separate world, has a separate language, separate concepts, and I think far deeper and far more complex than any other field in internal medicine. Not to say that the others are not important, extremely important. And my own philosophy is that a good neurologist should go through medicine first, internal medicine. They should go through psychiatry and then do neurology. So you need all three of these to be a really good neurologist. You need all three aspects. Nowadays, because of time constraints and so forth, they cut. So the person that comes just to focus in neurology, they don't have the background. They don't have the deep understanding. So the neurologic exam should be logical and focused. And this is my own personal approach. I try to make it logical, screening, practical. I spent 85% actually, or 90% on the history, and only about 10% on the physical. Because as you've experienced now the last week, the physical frequently is normal. Yeah. The neurological exam is normal. Yeah. Reflexes, every now and then, yesterday we found interesting abnormal reflex. Do you remember with kind of a Gordon Holmes type of reflex with the leg going out and then kind of standing there and then slowly settling. Frequently seen in thyroid disease. So that's very exciting, but that's unique. Just a point about practical, point about doing a quick general exam, like listening to the heart, listening to the carotids. Sometimes if we're concerned about a arteriovenous malformation or aneurysm, we'll listen for a bruit over the eyes. But a brief general exam is useful, quick general exam. And then you get into the neurologic exam. And then there are 5 elements to the exam. And then after you did the neurologic exam, kind of how to think about it. And how to approach neurologic diagnosis, because it's different from general medicine. Can you give me a handle? Can you give me a way to kind of look at the neurological problems. Now, you've done the history, you've done a quick exam. How do you put it together now? And how do you think about neurologic diagnoses? Anybody? Okay, so
based on the exam.
the what?
Probably based on the exam of the cranial.
Well, the history and the exam, okay, it's in your mind. But what does a neurologist then do? How do you try to formulate a conclusion or an evaluation or a recommendation?
Starting with consciousness and our mental functions.
Sure, that's all part of it. Consciousness, last minute, all that. But I'm talking about what is the approach that a neurologist.
Right. We could try to localize where the lesion could be.
Okay, so the first thing we do is neuroanatomy. I'm going to give you the basic approach to neurologic diagnoses, and it's 5 concepts. The first one is neuroanatomy. You want to know whether this is an upper motor neuron, lower motor neuron, whether it's cortex, whether it's spinal cord, whether it's cranial nerve. So you want to localize it in your mind, and you want to project that in terms of where the lesion is. Okay, we're going to call it a lesion. So neuroanatomy is the first step, right? So you have to learn anatomy, very important. You have to know where things are in the central nervous system, autonomic nervous system, and peripheral nervous system. So the first big question is this central nervous system? Is this peripheral nervous system? Is this autonomic nervous system? Okay, there are only 3 nervous systems. Everything can be subsumed under these 3. Okay, so anatomic localization is the critical element in neurology. That's the first step, anatomic localization. Number 2 is, in my mind, trying to understand the neurochemistry. It's especially important in conditions like Parkinson's disease or myasthenia gravis. So the chemistry, the neurochemistry of what may be going on. The third component is the neurophysiology, trying to understand the reflexes, trying to understand how things function. The fourth thing is to always develop a differential diagnosis. It's very good to have more than one diagnosis. So we call it a differential. I tend to do that all the time. Yesterday we had a patient with fairly classic trigeminal neuralgia, but in my mind I'm thinking, okay, what else? Rare, but what else could it be? And that way you're not going to miss things. Okay, so differential diagnosis is very important. And then finally, you have to come up with the best explanation. What is the best explanation? How many of you have heard of Occam's razor? Anybody Occam's razor? What is Occam's razor? Capital O-C-C-A-M. You've never heard of it. It's interesting that this is such a concept, important concept in medicine, generally medicine, especially neurology. We try to find the best explanation with the least amount of kind of input. Another way of thinking about it is that common things occur commonly. If you're looking for zebras, it's going to be hard to find. We have some students who are always thinking about the rare disease, but it's really most likely a common disease. So it's part of the heuristic, part of the teaching of neurology or guidance to neurology. Always think of Occam's razor sharp, trying to put things together that are most likely, rather than thinking of extraneous things. So this kind of guidance, Occam's razor, is really a guidance to all of medicine, but especially to neurology. And once you contemplated these 5 things, I usually like to consider testing to confirm my suspicions, my diagnoses, my differential diagnosis. And then only after the testing and the return of the testing, the treatment to be considered. So that's how I think. Now, this is just purely my approach to neurologic diagnoses. Okay, different doctors will have different approaches. Dr. Stein, I'm sure, has other approaches as well. And then as you go on in your studies, you'll have other physicians. But what I've tried to kind of distill for you, I'm coming. We have patients out there. Is my approach, and maybe I could just cover the rest of it quickly. The first impression of the patient is in the waiting room, long hallway, looking at the gait, G-A-I-T, very important in neurology, not so important in other fields in dermatology, for example. I'm picking on dermatology. I like dermatology, but I pick on it. For dermatology, you don't have to have a long walk. Yeah. Anyways, so even looking at gait, you're looking at posture, you're looking at station, Romberg. There are two things in the physical that are very critical. What are those two things that we always check? What are the two things in neurology that are so objective that you must?
Motor and the sensory.
The what?
Motor and the sensory.
The motor and sensory. Good points, but not those two. What are the two things that you must never not do? You cannot defend against it if you haven't done it. What are the two things? Two things in neurologic exam that you must do.
Cranial nerves and their ethers?
Well, you always do, yes, you check the cranial nerves, but there are two other things. And I've started telling you that this last week. Two things. We take the shoes off. Why do we take people's shoes off? Babinski is because that's an objective study. It tells you about upper motor neuron. If critical. If you haven't done the Babinski, you haven't done the neurologic exam. And the second thing is always look at the eye, look inside the eye, because you're looking for a central nervous system, you're looking for papilledema, you're looking for hemorrhage, you're looking for white matter changes in back of the eye, MS, for example. If you haven't done those two things, you haven't done the neurologic exam. And these two things are never done by the average neurologist, by the average doctors. The dermatologist is not going to do that. Family doctor frequently won't do it unless they're well trained. If you have in the olden days, 50 years ago, internists spent a lot of time in neurology. It was compulsory. Neurology they had to study neurology. Today, many doctors don't have, right? 2 weeks. So I'm telling you, doesn't matter what else you do, but you should always look at the fundi of thalamus. I have it here. Every room has one. And Babinski. So you always ask the patient to take their shoes off. We're the only doctors, neurologists, really are the only doctors that demand those two things. Okay. So I wanted to tell you that. Organize your exam. Organize it. Think about it. Focus. Be systematic. Separate central from peripheral from autonomic. Always localize the lesion. We mentioned, I think Dr. Avi mentioned localization, neuroanatomic localization. There's a purpose to doing that. History is most important. Loss of consciousness, amnesia. Mental status exam, when it can be important. The things I look for include recall, thoughts, to see if it's psychiatric, comprehension, probing, general intellectual functioning. And look at the arousal of the person. Are they awake, lethargic, sleepy? And sometimes we use the Glasgow Coma Scale, especially if you're in the emergency room. Always think about drugs, especially in this area here. But THC, everybody's now either eating or smoking marijuana. We're not supposed to use, by the way, the woke people say you can't use the word marijuana. It's called cannabis. So now you have to, you know, why? Because marijuana was thought to be kind of not woke. So I'm just trying to tell you that when you go on your training, cannabinoids, okay. Look for orientation, memory, intelligence, language, okay. Dominant hemisphere, you're looking for verbal memory and language use. That gives you a sense of the dominant, let's say the left side, dominant hemisphere. On the other hand, what are the features of the non-dominant? Anybody?
I think it's
Spatial
Construction, and
spatial awareness.
exactly, visual spatial awareness. And the construction, you're looking at the right side as opposed to the left. And then sometimes we do formal psychological testing, neuropsychological testing. I try to remember the asking these questions. For example, I use the word mind, M-I-N-D. What does that stand for? Mind. M stands for memory. I stands for intelligence or insight. N stands for numbers, numeration. Remember, we asked 7. And D, what does D stand for?
Drugs.
Drugs, depression,
Delirium.
delirium.
Dementia.
Exactly. And then the last 4 is jail. So think of mind, jail. Jail, J for judgment. What does A stand for? A, affect. I, we said intelligence, insight. And L, language. Exactly. So then you've covered it. Cranial nerves, we go from 1 to 12.
Dr. Bernard, the
Come
briefing is almost leaving.
Okay.
So I just wanted
I was trying to finish. Okay, let me leave it there.
Okay.
We covered a lot. Okay, but I'm going to go over the cranial nerves, motor, sensory exam. Okay. So let's go and see the first